While we're switching slides, I'm very pleased to introduce Dr. Dawn Comstock. She's an associate professor in the Department of Epidemiology, and she actually joined our faculty within the past year. And her research is on sports-related injuries, and I believe she's going to be talking about that, as you can see, concussion. And she's also a member of PIPER, the new program that I mentioned earlier in my introduction.
Thank you, Jill. It's great to be invited to speak at the first Public Health Exchange. And I'm really excited to talk to you about concussions because there's been this really amazing and rapid cultural shift in how we think about concussions over the last decade. A decade ago, when you talked about an athlete that sustained a brain injury, it was, oh, he had his bell rung, or, he got a little ding, and they were encouraged to shake it off and get back into play. And now, I would bet that even the most ardent sports hater among you has seen, heard, listened to, read about some sports concussion story in the last few years, probably in the last few weeks. And we really recognize now that concussion is a public health concern. But before we go there, we're public health. This is an awesome opportunity to get a little education and do a knowledge evaluation. We're the only injury thing on the docket here. So, almost all of us spend substantial amounts of time in Building 500. I bet all of you can immediately envision the two closest fire escape routes close to your workplace, right? Yeah, I see your heads nodding. That's good. All right, now I'm going to put some of our leaders on the spot. Dick, does CSPH have a first aid kit? And if so, where is it? Oh. You're Tim, if you're walking down the hall and Denny is talking to someone who clutches their chest and keels over. It's his responsibility. All right. And this happened recently, right? This spring, tornado warning. Jill, where are we supposed to go to shelter from a tornado? Okay. Good answer. Who lets us know when it's okay to come out? Come out of shelter. The voice. The voice of God. Good answer. And I was going to put Dean Goff. Here he is. Good. Perfect timing. Dean Goff, I'm putting you on the spot. Building 500 safety quiz. Does CSPH have a disaster plan in case of fire, bomb threat, something like that?
I'm sure we do. Absolutely positive.
All right.
I was here when they had that tornado warning.
Right.
And we all went into the hallways and down into the basement as we were told.
Yep.
And we stayed inside, which was appropriate.
Very good. Until somebody told us the voice of God told us we could come out.
And I'm sure that if something else happened, we'd hear the same sort of stuff. And we have the RAID system that tells us what.
There you go. Yep. Good answer. All right, so ideally with the disaster plan, we'd actually have a plan to evacuate, to meet someplace, to have people responsible for counting heads, seeing if anybody was still in the building. The take-home message here is that we all know that we should know the answers to these. And that if we do know the answers to these, then workplace health and safety will be greatly improved, right? We'll minimize workplace injury if we can answer these and put them into practice. But how many of you either played sports as a kid, have kids that played sports, have kids that currently play sports, or you expect to play sports? Yeah, almost everybody, right? Have you ever thought about any of these questions? Okay, I see a few heads going up and down, so that's good. We don't think about the fact that the same kind of questions about general workplace safety we should be asking about sports safety. You should be making sure that your coach has the right education, certification, qualifications. You should be hopefully making decisions with your child about what sports they play based on sports risk factors and watching out for injuries based on which injuries are more common in which sports. When you drop your kid off at practice, who's actually going to make the call to remove them from play if it looks like they have an injury? And who's literally going to make the call to EMS if they have a severe injury? These kind of questions we should be asking to reduce sports-related injuries, just like those other questions can reduce workplace injuries. And I use that just to kind of demonstrate part of the challenge associated with doing sports injury epidemiology. We know that we can take all the same skill sets that we use in all the other areas of epidemiology, and we can dramatically improve athlete health and safety if we apply them to sports. But it just hasn't been done very often yet. We're way behind the curve. And there's a bunch of reasons for that. General challenges mirror the challenges specific to concussion research. A lot of it's just the culture. Injuries are just part of the price you pay to play. It's part of the game, those kind of things. Lack of knowledge about exactly what's going on. We have so few resources, so few research in this area that we really are just starting to build a knowledge base. Funding, we all have funding problems, of course. And just the resources to be able to do this kind of work. Really getting into those communities, getting the community stakeholder buy-in to do this kind of research. So I entered this field kind of knowing all of these challenges, in part because it's also really exciting to help build a new field, a new line of research. And I kind of tried to address some of these challenges through my main research project. It's the National High School Sports-Related Injury Surveillance System, kind of been branded as High School Rio. It was kicked off with a one-year New Investigator CDC award, which they don't give out anymore, unfortunately, for $100,000 back in 2004, let me develop and implement this injury surveillance system that first started collecting data in the 2005-2006 academic year. And we're currently in our 9th year of data collection. So I use athletic trainers from a couple hundred high schools all across the country as my data reporters. They report data to me through an internet-based data collection tool. And they report every injury that occurs as part of a school-sanctioned practice or competition that comes to the attention of an athletic trainer or a physician, requires their care, and it has to come to the athletic trainer's attention or they wouldn't know about it to report it to me. And then any injury, it's a time-loss injury, so it results in the athlete being kept out of play for at least 1 day beyond the day of injury, as well as all concussions, fractures, and dental injuries regardless of time loss. And we also collect information on athletic exposure, so one athlete participating in one competition or one practice. And here's a link if you wanted to go to it. You can actually, the demo internet-based data collection tool is online. If you just type in High School Rio Piper, you'll get right to that page. You can see what we ask and what we collect. But like I said, we collect exposure data, which is really important so we can calculate rates. We collect injury incidence information. And for every injury that's reported, we collect, the athletic trainers fill out a big injury report form. So we collect up to 300 individual variables on every injury. Information about the athlete themselves, age, height, weight, what their year in school is, what sport they're playing, what position they're playing. Information about the injury, body site injured, diagnosis of injury, severity of injury. Information about the injury event. What was the mechanism? Athlete-athlete contact, athlete-surface contact, athlete apparatus. What was the specific sports activity? In football, were they tackling or being tackled, blocking or being blocked, things like that. So we have a bunch of information that we collect on every injury. And these are the sports that have been included in High School Rio over the past 8, now 9 years, and how many years we've collected data on them. So this is the data that's already in the bank as of the end of last academic year. And you can see when we started out 9 years ago, we had 9 sports that we were interested in. So all those sports that have 8 years of data were in the bank. And those sports were chosen because they're popular. A lot of young athletes across the country play them, but they also have a relatively high risk of injury. And then over time, we added more sports and more sports. And last year, actually, for the first time ever, we dropped 2 sports. We dropped boys volleyball and girls gymnastics because so few high schools across the country are offering those programs anymore. Boys volleyball was never really popular outside of Hawaii in Southern California. And girls gymnastics, just because of legal issues and because of the shift to having that be a club sport intense activity, we've just dropped those. And instead, we added boys and girls cross country. So you might think, why are you adding track and field, swimming and diving, cross country? Those have pretty low injury rates. And that's true, but they have incredibly large number of participants. And they also are higher risk for overuse chronic injuries. So through the first 8 years, Tasha has a big data set. I have a bigger data set. We now have a data set that contains 50,000 sports-related injuries that were sustained during 25 million athletic exposures. So this is really fun because we're now at the point where we can start to do some kind of cool statistics with these because we have some power that we didn't have before. So really basic stuff. When you do that calculation, it comes out to about 2 injuries per 1,000 athletic exposures. So, you can kind of generalize that to say that for every 1,000 kids that are playing or practicing sports across the country, any of those sports in our survey, 2 of them are expected to sustain an injury. I mean, think about that. Or alternatively, for your child, every 1,000 days they participate, you expect about 2 injuries. And those are time loss injuries, mostly. When we look at the incidence, it's pretty well split between competition and practice, about 50-50. But if you think athletes spend a lot more time in practice than they do competition, so the rate of injury is much higher in competition than it is in practice, 3 times higher. And obviously, rates of injury vary pretty dramatically by sport. The full contact or collision sports have much higher rates of injury than sports like soccer or basketball, where a lot of contact occurs, even though it's largely prohibited by the rules. And sports where there's very little contact have the lowest injury rates. And you see also that difference between practice and competition rates also varies pretty widely, even though the vast majority of sports have higher competition rates than practice rates. So one of the neat things is now that we have 9 years, we're working on our 9th year of data collection, we can really start to look at some trends over time. And we see that overall, injury rates are decreasing. High school sports-related injury rates are decreasing over time. That's good news, right? But I told you I was going to talk about concussions today. Whoa, yeah. I like that response. That's good. Not good for the kids, but it's good for a presentation like this. Yeah. So concussion rates have increased significantly over time. The black line is competition-related rates, the gold line is the overall combined practice and competition, and the gray line is the practice rate. And the practice rate is really right on the cusp of statistical significance. It's not quite there yet. So obviously, if the overall injury rates are decreasing at the same time that the concussion rates are increasing, then concussion is representing a larger and larger burden of the overall injury among high school athletes. And that's exactly what this graph shows. Back in 2005, 2006, 2007, when I first started doing this injury surveillance work, concussions represented 8-9% of all of the injuries reported to the system. Now, the last couple of years, you see it's over 20%. It's nearing 25%. Now, that's a pretty shocking number if you think about it. If you think that 25 or nearly 25% of all of the injuries sustained by high school athletes are concussions. And a concussion is a brain injury. Every single concussion, no matter how mild, is a brain injury. The definition is a disruption of normal brain function due to a transfer of force. Now, do I really think that 1 out of every 4 injuries is a concussion? Probably not. I think that huge cultural shift that we've seen, the pendulum has probably swung a little too far, and we may actually be overdiagnosing at this point. But that might not be a bad thing. Better safe than sorry, all that good stuff. So I've shown you a bunch of shocking graphs that show concussion is on the rise, so there must be time for action, right? It's time for us to do something. And in fact, look, here's a JAMA quote. But wait, it's from 1928. In 1928, in a manuscript on describing the punch-drunk phenomenon in boxers, the author showed a definite correlation between blows to the head and concussion and said, the condition can no longer be ignored by the medical profession or the public. We ignored it for a really long time. Not a lot of readers of JAMA back then, evidently. So the question is, what does it take to get people to pay attention? And I think, unfortunately, or fortunately for us as public health, because we use the media to help us get public health education messages out, I think the media really helps. Huge media attention over the last 5 to 8 years on this issue. And last week, or 2 weeks ago now, August 29th, it was reported by ESPN that the NFL had reached a $765 million settlement with their players' union over concussion. That's the kind of number that grabs some attention, right? And hopefully really brings about some action. Now, good news, bad news. Good news for the players, the vast majority of that money is going to player care. Good news for us, about $10 million of it has been earmarked for concussion research. And this week, I don't know if anybody heard, there's been several recent former collegiate athletes that have just filed a class action lawsuit against the NCAA that mirrors this. And us in academia, we pay attention to the news once in a while too. These are PubMed keyword results. So concussion has also become a hot topic for researchers. You see the number of manuscripts with, if you do keyword searches for concussion, concussions, or MTBI, minor or mild traumatic brain injury, you see those have really skyrocketed over recent history as well. So high school Rio wasn't intended to be a concussion surveillance system. It wasn't. But we just happened to be in exactly the right place at the right time. There's been a previously published GAO report, and there's a forthcoming IOM report that both state that there are 3 surveillance systems currently available to provide national data on sports-related concussions. The Consumer Product Safety Commission's National Electronic Injury Surveillance System, which is an ED-based system only, the NCAA's Injury Surveillance System, which is collegiate athletes only, and my high school Rio system. So we were really lucky to just be in the right place at the right time. And as a result, we get to publish a lot of information that, like I said, kind of helped to build the body of research in this field. Way back in 2007, we were the first, my research team was the first to directly compare concussion rates in high school and collegiate athletes. And we found that although concussion rates were significantly higher in collegiate athletes, concussions represented a greater proportion of all injuries among high school athletes. We also found that in gender comparable sports, girls consistently report higher rates of concussion than boys. And same thing in collegiate, females report higher rates than males. We don't know if it's a true biophysiological distinction or if it's a sociocultural distinction associated with reporting habits. In 2009, we reported that way too large a proportion of athletes were returning to play before the current accepted guidelines. And in fact, 16% of football players who lost consciousness as a result of concussion returned the same day, which should never happen, no matter what. That study was cited repeatedly as each individual state was passing their state-level concussion legislation. So that was a really cool example of research driving some policy. Later on in 2010, we did some more kind of basic epidemiology and identified some factors that maybe we could intervene with. We see that the vast majority of concussions in all sports are athlete-athlete contact, even swimming. The most common mechanism of concussion in swimming is when they're warming up with multiple swimmers in a lane and they drift a little bit and run into each other. So even in swimming, the most common mechanism of concussion is athlete-athlete contact. But that's good, because if we know that, now we can target some interventions. The good news is that the vast majority of high school concussions are very minor. 83% have full resolution of symptoms within a week. That's good news. We followed up our 2007 study with some more detailed look at gender comparisons in 2011, and we found that even though the rates are different, there's no gender difference in the number of symptoms that female and male athletes present with, but there is a significant difference in the type of symptoms they present with. Girls present with more somatic symptoms, symptoms that aren't outwardly apparent to an observer, like light sensitivity, noise sensitivity, while boys present more commonly with cognitive symptoms that you can see, like transient amnesia, extreme confusion, loss of consciousness, some of those things. Computerized neurocognitive testing has really been pushed by the media and pushed by the marketers that are making money off of it. So we look to see how is it actually being used in the high school setting. And 40% of all the high schools with athletic trainer coverage are using it, but very, very, very few are having a neuropsychologist or someone else who's considered to be an appropriate authority evaluate those. So that's an interesting, we want to make sure that they're not being used to let athletes return to play too soon instead of what they were originally intended to. We've looked at a broader group of sports instead of the original 9. And we found that concussion rates vary widely by sport, but they occur in every single sport. So your kid is not concussion safe, even if you send them into tennis or track and field or anything. We didn't look at tennis, though. Sorry, bad example. We've also now started to look at things, we're very concerned about things like second impact syndrome. You've probably heard of that. An athlete who gets a second concussion before they're fully recovered from a first concussion, and they have very severe negative outcomes, including death, frequently. So we don't have any second impact syndromes in our data set, thank goodness, but we did look at recurrent concussions versus initial concussions. And we found that luckily the rate is much higher of new concussions. That's good. We're not getting a high rate of recurrent concussions, but the recurrent concussions are significantly more likely to have long-term symptomology. We're talking longer than a month. When an athlete still is symptomatic after a month, that's very, very concerning in terms of their long-term health and well-being. And we see a much higher proportion of those recurrent concussions having those lingering symptomology. And then we're also able, like I said, to start playing with, because the data set's so big, to even start playing with trying to do some prognostication. Some researchers that collaborated with us found that student athletes that present with 4 or more symptoms were significantly more likely to have their symptoms linger longer than a week. And also, those who had a prior history of concussion were more likely to have those lingering symptoms. So that helps clinicians kind of, the first question that every parent wants to know is, when can they go back to play? When are they going to be better? And now maybe we can start helping those clinicians give some of those prognostications. So that's kind of what we've done in the past. But I thought today was so cool because we have all the different concentrations together. And I think the School of Public Health is so unique because even though we have our individual concentrations, in reality, we're really all collaborative and cross-cutting. So I wanted to take just a couple, we got a whole bunch of pots on the stove, but I wanted to take just a couple of our projects and show you how they kind of cross over into other areas. So I've already talked about epi and biostats, but how about HSMP? We've done some studies to try to look at where kids actually present for care, those kind of clinical presentation patterns, and what that actually means. And what we found is that it's really important to look across the entire continuum of clinical care. Almost all of the research that was done previously that keeps getting pointed, that all the decision making is based on right now, is emergency department and hospital based. And when you look at this, what we found is we looked at one big children's hospital facility with a whole bunch of clinical settings, ED, on-site, urgent cares, off-site, outpatient clinics, the whole shot. And we were smart. We used their billing records. So if they billed for any code that's associated with any kind of TBI, we captured it. And what we found is only 30%, only a third present to the emergency department. So all that decision-making we're basing on ED data is just tip of the iceberg in terms of what's really happening with TBI. And codes varied by clinic. So where you present determined what code you got, which is terrifying when you look at codes. Cost also varied by clinic. So in terms of CBH, we've been able to evaluate education of coaches and show that the higher the level of education, the better the coach's decision making. Simple as that. We've been able to look to see if changes in policies like education about tackling technique have been effective. And we've been able to prove that it is. And even some of those kind of policy decisions about medical coverage. If a school has enough money to offer a football program, they should have enough money to have an athletic trainer on staff to provide care to those athletes. Okay, so I talked about EPI, I talked about biostat, I talked about HSMP, I talked about CBH. How the heck do I get environmental health into concussion? I intentionally left off the O because I'm talking about kids, so I didn't want to talk about occupational. Good catch, though. So environmental health, I guess I could look at field surface or field quality, maybe, a built environment. But I had the opportunity, one of the funnest projects that I've ever had somebody approach me with, I had some guy call me up completely out of the blue and said, I think concussion risk is associated with, whoops, that's legislation, sorry, is associated with elevation. So we looked at the location of all the high schools that report data to us. The median elevation was 600 feet. We had from 6 feet all the way up to 6,000 feet. And I couldn't believe it when I looked at this data, and he was right. Elevation appears to be a protective factor against concussion. And the biophysiological rationale is that at increased elevation, there's increased intracranial pressure. So there's a little less space for your brain to slosh around inside your skull when you take an impact. So the good news is, living in Denver, we're probably protected against the most minor of concussions. The bad news is if you look farther down at symptom comparison, if you get hit hard enough, it doesn't matter. So we have fewer of the minor ones, but the ones we have are more severe. And where does that go? What do you do with data like that? You hook up with some really smart people that are trying to develop a brand new piece of protective equipment. We actually have an R01 under review right now for basically an inflatable neck gaiter that athletes could wear to alter their intracranial pressure at different elevations. I have no idea if it'll work, but how fun if we help develop a brand new piece of protective equipment. Thank you. Yes, sir. Thank you.
I was just wondering, with the fear of litigious situations, I'm wondering about the quality of the reporting of these particular injuries, and did you guarantee anonymity to the schools that actually reported?
Yeah, thank you so much. You let me use a pocket slide of one that I didn't have time for. You're right. The first state-level concussion legislation was the LISTAT law that was passed in 2009, and it rapidly spread across the entire country. Colorado passed their concussion legislation in 2011, and at this point, all states but the state of Mississippi, go figure, Mississippi, all states but Mississippi have concussion legislation. So you're right. We have complete anonymity. First of all, the surveillance system was set up several years before the first state established legislation. So we had already established ourselves as a quality group of researchers. There's no personal identifiers in the data set. There's no identification of any schools involved ever. And we had built up that trust within the community, that grassroots sports community. So we didn't have any problem at all as these legislations started popping up. In fact, we currently have a grant from the CDC to evaluate the effectiveness of the state level legislation. Because we have such a large, robust data set and we're so good at confidentiality, we can look at it without having any litigation concerns. Yeah, so two great questions. One is, are we looking at middle school kids? So, I told you that there's emergency department data, there's collegiate data that's been around for 30 years. I've only been doing high school data for 8 years. There just aren't the resources right now to try to do younger youth surveillance. We did do a very small study funded by NFL charities where we looked at middle school aged football players compared to high school football players. And what we found was the trends that we see from high school to collegiate hold, they just go the other direction. So the middle school athletes have even lower concussion rates, but concussions do occur. And the symptomology is very similar. The recovery time, things like that, are actually similar. So it is concerning that right now there just, quite frankly, are no resources. Everybody loves using surveillance data, but nobody likes to pay for surveillance systems. So I think many of us are chomping at the bit. If there's ever money, we would love to look at younger age groups. The second question was how the schools actually work with it. That's a great question. We have tons and tons and tons of information and a huge building database on return to play, and almost no work has been done on return to school. And there's a lot of reasons for that, but that's a big open area if anybody wants to come in and make their mark.
Thank you.
Thank you.
I know that there are other questions.